Hi, and welcome to Rapid Respiratory Review. And today we're going to be talking about metabolic alkalosis. Metabolic alkalosis is very common in acute illness. It's the most frequent acid-base disturbance in hospital. And how is it caused? It's caused by a loss of fixed acid, such as your phosphoric acid, your sulfuric acid, or your ammonia, or an accumulation of blood base. So I remember this through an acronym called EGBASH. Eucapnic ventilation post-hypercapnia, gastric fluid loss, bicarbonate administration, alkali ingestion, steroids, and hyperaldosteronism. And we're going to talk about each one. So eucapnic ventilation post-hypercapnia. So if you're going to give a patient permissive hypercapnia in ARDS and asthma, in chronic CO2 retainers, it leads to your kidneys compensating and increasing your bicarbonate retention due to your increased acid, your respiratory acidosis. And if CO2 is allowed to normalize too quickly, it will result in a metabolic alkalosis if you were just to take them off the vent instead of just weaning slowly. And a treatment for this is maybe give carbonic anhydride inhibitors. Another one is gastric fluid loss. So loss of gastric secretions, and it's probably the most common. It can be caused by prolonged vomit or NG or OG section. And when gastric fluid, so how does this happen? When gastric fluid is lost, new HCl must be produced in a reaction that produces HCl in the stomach and causes your bicarb to enter the blood in exchange for your chlorine. So the more acid you get, the more acid you lose in your stomach will want more acid there. So you'll get more chlorine passing and conversely more bicarb into the bloodstream. Bicarbonate administration. It's used periodically in the treatment of metabolic acidosis. And if you're going to overcorrect by adding just your exogenous to the plasma and not really knowing what it is intracellular, then you can give too much because you're adding an exogenous to an endogenous, what's produced inside and what you're giving from outside. Alkali ingestion, large amounts ingested over a long period of time. So anything that comes on in an alkaline, such as almonds, potassium, sodium, those things can start to cause it. So excretion may not be able to keep up with the alkali load, so maybe your kidneys can't pee it out, or you're not properly having good stool with it. It's especially true with individuals with low extracellular fluid, so really young or really old, or impaired renal function. Can also be referred to as the milk of alkali syndrome, so you just have all these alkalines and you keep just drinking milk or sodium, almonds, potassium, like I said, and it could cause this. In patients with peptic ulcers who continue to drink milk, it's more common, and in some parts of China, it can be due to licorice ingestion. Another one, steroids. It's similar structure to mineralocorticoid aldosterone. Thus, when done over extended periods of time, it makes hyperaldosterone, and you have a constant activation of your RAS system, your renin-angiotensin system. What it causes is sodium and water retention, potassium and H+ secretion, so you're losing your acid and thus causing metabolic alkalosis. Hyperaldosteronism, increased aldosterone secondary to stimulate the adrenal, so if you're always in a state of high adrenal, then it can lead to inadequate renal or it can be caused by inadequate renal perfusion, such as RAS activation, CHF dehydration, hypovolemia, renal stenosis or renal hypertension may result, or diuretics, such as contraction alkalosis with hyperaldosteronism, hypokalemia, and metabolic alkalosis when you're giving Lasix. That's all for today. Have a great day.